speech.
Okay, thank you very much. Dear organizers of the International Congress of Sport Medicine in the 21st Century, dear fellow participants, I really believed in the quality of the information that we have received during these days, and now I see that the Congress exceeded my expectations. And I'm sincerely delighted with the quality of the lectures as well as the work of your technical service and computer support, and thank you for that. I'm grateful to the Scientific Committee for recognizing and including in the Congress program a significant problem of exercise with artificial limbs, not only as a global phenomenon, but also a phenomenon I had the opportunity to explore at the Department of Sports Medicine of the School of Medicine at the University of Belgrade. Θα προσπαθήσω η διάλεξη μου να είναι το πνευμά της ρίζης του Αριστότελη. Όταν κάποιος με τα λίγα λέει πολλά, τότε αυτός γνωρίζει πολλά. By inspecting the gait in patients with lower limb amputation, I learned that a huge problem for people with transfemoral amputation is not only lack of motivation and perseverance in implementing long-term recovery program, but also insufficient representation of appropriate quality and safe prosthetics, combined with modern information and communication technologies and the scientific research. This is confirmed by the relatively small number of available research results, about 1,800 of them, mostly not older than 5 years. Now I have a problem for putting this. Okay, I succeeded. The main problem with conventional leg prosthesis is that they do not convey sensory information about motion or interaction with the ground to transfemoral amputees, thereby reducing walking speed and confidence in users that is associated with high mental and physical fatigue. The lack of physiological feedback from the remaining extremity to the brain also contributes to the generation of phantom limb pain from the missing leg. This is a situation that has nothing to do with just stated lack of motivation and perseverance. Here we witness the rule of one that applies in elite sport. Athletes win by 1 split second, by 1 centimeter. In collective sport games, they are winning by 1 goal. And Oscar Pistorius belongs to 1 per mil of elite athletes who won the Olympic medal. Ελπίζω η διάλεξη για τους διαμοιριός ακροτηριασμός είναι σαν βαρετό δημοσιογραφικό ρεπορτάζ. Frustration, reduced walking speed, greater energy expenditure, higher oxygen consumption, disturbed walk pattern, lower back pain, postural changes, and phantom limb pain lead to 80% of patients with transfemoral amputation who prefer a wheelchair. And to say something about amputation, many prosthetics have recognized the problem of the abducted residual femur and have attempted to solve this problem by creating a socket with a larger anteroposterior versus mediolateral dimension. The significance of moment arm to adducted position of residual femur is evident not only because of bone and muscle length, but also of an angle at which the muscles are attached to the distal part of femur. Skin flaps should be marked out prior to the skin incision, while anterior flaps are fashioned longer than posterior so that the suture line is placed posterior. A long medial flap in the sagittal plane is also acceptable, and any flap configuration that will enhance feasible preservation of length is acceptable. The adductor magnus muscle is detached from the adductor tubercle by sharp dissection and reflected medially to expose the femoral shaft. It may be necessary to detach 2 to 3 centimeters of the adductor magnus muscles from the linea aspera. The femur is exposed just above the condylar level and is cut with a power saw using an oscillating blade so that the femur is transected approximately 7.5 to 10 centimeters above the knee joint line. The adductor magnus tendon is sutured with non-absorbable or long-lasting absorbable suture material to the lateral aspect of the residual femur via the drill holes. When it is about today's lecture, I need to emphasize the fact that all the knowledge of this world is someone else's knowledge, and that the reason I'm able to present you today this fascinating data is that I stood on the shoulders of the giants. Those giants are Professor Petrini, Professor Raspopovic, Professor Bumbashirevic, Professor Ilic, Professor Bortolotti, Professor Mazic, and all other members of this large scientific team. Today's lecture represents an update of the research presented in 2018 at the Hellenic International Congress and conducted with an aim to identify the specific biomechanical factors in patients with transfemoral amputation while walking on different surfaces and conditions. The testing protocol involved kinematic gait analysis over ramp, stairs, and obstacles, and the term different conditions mean conditions with or without neural sensory feedback. So let's just remind us what the results were. It was determined that comfortable walking speed was significantly higher during neural sensory feedback compared to the no stimulation trials, as well as all other examined biomechanical parameters. In a recent study of Petrini and Associates, it's a magnificent study published in Nature Medicine in 2019, 2 volunteers with transfemoral amputation were implanted with 4 transversal intrafascicular multi-channel electrodes in the nearest portion of the residual tibial nerve. Research was oriented towards examination of biomechanical and physiological parameters. Examination of the surgical procedure from the research could be divided into 3 steps. Step 1, the implants. The implants are positioned to cross the majority of fascicles in a very close longitudinal space shown in the pictures above. Step 2, the cables are fixed by flap preparation from the fascia tissue and shown in the bottom left pictures. And step 3, the electrode cables are tuned through the thigh and pull out of the leg through small incisions just a few centimeters below the iliac crest, with the aim to enable transcutaneous connection with the neurostimulator. The bottom right picture includes as well electrode positioning shown in the X-ray taken before explantation. So in case you missed this lecture from 2018, please let me explain briefly the research methodology. Neuroprosthesis consists of the intraneural electrodes sensoid insole located under a custom-made transfemoral prosthesis and the microprocessor-controlled knee with an integrated knee encoder, a stimulator, and an external controller. Short pulse trains of electrical current, varying in intensity, duration, and frequency, are injected into each of totally 4 active sites. The readouts of 3 of the insole pressure sensors and the knee encoder are used in the control inputs. Okay. The map of sensation is used to calibrate a neuroprosthesis. That is the slide with sensation characterization. And it is determined that walking speed and self-reported confidence increased while mental and physical fatigue decreased for both participants during neural sensory feedback compared to the no stimulation trials. Furthermore, participants exhibited reduced phantom limb pain with neural sensory feedback. In the study of Claret and Associates, all these studies that I'm talking about are recent and not older than 5 years. It is suggested that besides the asymmetry in the load distribution, there are neuromuscular adaptations after an amputation, possibly related to the loss of sensory feedback and an altered sensory motor integration. The intact leg of amputees seems to compensate for the mechanical limitations and loss of somato sensation in the prosthetic limb. In relation to non-invasive research methodology, Wimmel and Associates conducted a study dealing with the limit of stability and sway analysis during shifting exercise with a vibrotactile sensory feedback in transfemoral amputees. It is concluded that the vibrotactile sensory feedback system shows a great potential to improve the limit of stability and balance during weight shifting exercise. Mentioned device could be added with the prosthesis as a feedback system for an amputee, which may decrease the visual demand for improving stability. However, in the study of Petrini and associates from 2019, it is stated that vibrotactile and electrocutaneous non-invasive sensory feedback devices show only limited benefits such as improved symmetry between prosthetic and healthy legs during walking on even surfaces and the postural stability on a movable force platform. In one more study based on a non-invasive methodology that included 14 transtibial unilateral leg amputees, patients used their own prosthesis equipped with a non-invasive somatosensory feedback system during 10 days of prosthesis training. 2 electrodes were mounted on the residual limb and the subjects learned to discriminate the 3 possible stimulation patterns. The somatosensory feedback kit included 3 pressure sensors fixed to the sole of the prosthesis foot at the load line of prosthesis foot. And the final results show that training with somatosensory activity feedback system providing electrocutaneous feedback to the thigh during walking reduces considerably phantom limb pain and improves functionality of movements with the prosthesis for some patients. Different feedback modalities, including visual, auditory, and haptic feedback, have been the most commonly implemented approaches. However, non-invasive systems have the drawback of not being homologous or selective. They do not restore sensations from the missing leg, or they evoke even unrefined sensations. These drawbacks force the amputees to invest time in training, which only partially overcomes such a limitation. The implantation of the electrodes performed under general anesthesia seems to be the gold standard for the transfemoral amputees at the moment. However, full implantable device without transcutaneous cables needs to be developed to allow more robust investigations. Studies show that the somatosensory feedback especially improves functionality and those precise mechanisms that underlie the beneficial effects of feedback prosthesis are not completely known for the moment. With respect to central factors that contribute to phantom limb pain, both the functionality of limb and pain in limb are associated to the reorganization of the primary somatosensory cortex. Further research is needed to identify underlying mechanisms and their relative contribution for phantom limb pain reduction when feedback prostheses are used. Paradox is the fact that at the historical scale, the progress of humanity has never been greater, faster and more significant than it is today. And yet, observed through the eyes of sports science and medical science, it could be said that we do everything the opposite and against ourselves. It could be concluded that we are taking a step forward just to make 3 steps backward. Regardless of the fact that we are contemporaries of the increasingly intense interaction of the human species with advanced technologies, and that it cannot be stated with certainty in which direction this interaction will develop, it is likely that the physical activity will continue to take place in accordance with biomechanical and physiological laws, and that it will continue to be a powerful tool in preventing, solving, and overcoming numerous health problems. Perhaps there will be a dawn in which modern science will describe the full circle and return to the original values. Δοξά στην Ελληνόσερβική Φιλιά. Ευχαριστώ πολύ.